And now, a moment we've all been waiting for, Dr. Sullivan, Dr. Kathleen Sullivan, who is with us tonight, is going to, as I said, present a few slides and then move right into questions. Thank you to everybody for the questions you have submitted. We've received hundreds. And as I said earlier, we have grouped them together so that we can have Dr. Sullivan answer as many as possible. Now, Dr. Sullivan is board certified in pediatrics, in pediatric rheumatology, and she is the chief of the Division of Allergy and Immunology at Children's Hospital in Philadelphia. She has written or co-written over 200 publications in medical books and journals. And this year, at the recent IDF PI conference, IDF recognized Dr. Sullivan's significant contributions by presenting her with the IDF Community Hero Award. Thank you. So right now, please join me in welcoming Dr. Sullivan.
Thank you, Kathy. And so I decided to tackle a few of the questions head on and just cover them in a formal way, but by far the majority of the time is going to be to answer your questions. So I'm just going to get started because the things that I tackle in the slides are by far the most common questions that I get. So these are the topics that I want to cover. So vaccination for people with antibody deficiencies. So not all PI are antibody deficiencies. So I want to focus specifically on those with antibody deficiencies. I am definitely going to cover antibody testing. I get asked about antibody testing every single day. And then we'll talk about antibodies in immunoglobulin products, which might be an aspect you haven't thought about. And then what's COVID like for people with PI? And then, as I said, most of the time, this is about 10 minutes. Most of the time really is dedicated to your questions. So the vaccine response in people with PI, this has been a huge surprise. And so this is the best study. There are actually several studies that say roughly the same thing. I picked this study from David Hagen because it has the most patients and the best documentation. So let me walk you through this graph. When you're looking at the graph, on the left-hand side in the light pink are the antibody levels. So on the y-axis going higher is more antibody. So the pink symbols that you see are people before they ever get the vaccine. So you can think of this like the baseline. Now, if you go over to the far right, you see some green symbols. Those are people who had natural infection with SARS-CoV-2. So they had clinical COVID-19 and ended up getting testing. You can see that their levels are higher. They're above that dotted line. But here is an important point. If you compare those to the yellow symbols, so the yellow symbols are healthy people who got the COVID vaccine. And for this particular study, almost everyone got one of the two mRNA vaccines. You can see that the people after natural infections have far less antibody than the people that got the vaccine. And so if you've heard people say, even if you've had COVID-19, you should still go ahead and get the vaccine. That's why. The vaccine induces much higher antibody levels than natural infection does. But here's the meat of this graph and why I'm showing it to you today. In the, I'm going to say burgundy colored symbols, these are all people with PI. And there's different types of PI here. But you can see there's actually kind of three clumps. So in the bottom, there's a subset of people who don't respond at all, right? They have the same amount of antibody as the people pre-vaccine, that pink group. So there's a small group of people who don't respond to the vaccine at all. There's a group of people who respond kind of in the middle, and they have antibody, but it's kind of at the level of those who have natural infection. And then there's a big group of people at the top here, and they have the same amount of antibody as the healthy people who got the vaccine. So what are in these groups and what does it say to us about people with antibody deficiencies getting the vaccine? So just today in clinic, A mother told me, why should my son get the vaccine? He didn't really make antibodies to the pneumococcal vaccine. He didn't have great antibodies to the tetanus vaccine. Why are you telling me to go get the COVID vaccine? And it's because these RNA vaccines are so strong that even people with antibody deficiencies, with the exception of X-linked A gamma globulinemia, still have a very good chance of making an antibody response. So even if you didn't respond to the pneumococcal vaccine, there's a good chance you will respond to the COVID vaccine. And I think this is really important. If you look at the two lists that I've put over on the right, I just took the diagnoses that either did not respond to the vaccine at all or that did respond to the vaccine. And so I personally think it's very appropriate, even if you're antibody deficient, to get the vaccine. That's my opinion. A few more specifics. So here it's the same data from the same study, but they divide it according to the specific diagnosis. So I just put up a list. Here you can see the actual data, and you could see within the group that has common variables, so these two CVIDs down here at the bottom, you can see that in their minds, they made a distinction between elderly with CVID who had some lower antibody levels versus the younger people with CVID who had antibody responses more typical for the general population. And then this group down here that says B negative, these are people with no B cells at all, the cells that are responsible for making antibody. So they did not do well. They did not make a lot of antibody to the vaccine. But most of the other patients actually did. So what are my take-home points from this study? And again, this is, I think, by far the best study, but there are other studies with very comparable data. Most patients with CVID will make antibody to the vaccine, which is a huge surprise and a wonderful surprise. Most patients with XLA or X-linked A gamma globulinemia will not make antibody to the vaccine. And then there's a few little sprinkles of different diagnoses in between. But I think these are important take-home points. Is there more than antibody? So this is a difficult slide. I'm going to walk you through it. This is a study from mice. We don't actually have any data from humans yet. So I'm going to share with you this experiment that they did in mice to try and answer the question, if you don't make antibody, is there any benefit to getting the vaccine? So what they did was they infected a mouse with SARS-CoV-2. Yes, you can do that. And then they waited for the mouse to get over the infection. And from that mouse that was previously infected, they either took T cells are the white cells that actually kill virus, or they took antibody and they put it into another mouse that had never been infected. And then they asked which of those are most protective. So if you look at the graph on the right, the black bar, what they're measuring on the y-axis is how much virus is in the mouse's body. So mice don't get sick the way we do. They don't cough, they don't wheeze, they don't lose their taste or smell, at least as far as we know. And so the way to measure how infected they are is to actually ask how much virus is in their little mousy bodies. And so the control, the black bar here, the high level here means that the mice that didn't get either the T cells or the antibody had a lot of virus in their body. They weren't controlling it very well at all. For the mice, for this red band here, the way they did this experiment is they transferred the experienced T cells, these cells that are actually responsible for fighting the virus. And you can see the mice that got the T cells had some protection just by getting T cells and no antibody. Of course, having antibody is best. Those are the blue dots at the bottom. The mice that got the antibody from the infected mice, they did great. They didn't get sick at all, and they didn't have any virus in their body. But the people that got the T cells, the mice that got the T cells were somewhat protected and had less virus in their body. So we think that even if you don't make antibody, you still get some benefit from the vaccine. So based on this, I recommend the vaccine for almost all of my PI patients. but you should check with your immunologist. Maybe you have specific considerations, and it's always good to hear from the doctor that knows you best. But because even people who don't make great antibody, I think still get some benefit, it's a rare patient where I don't recommend the vaccine. All right, let's move on to antibody testing. This is a shorter little vignette here. So I am often asked, should I get the antibody test? I got the vaccine. I want to know for sure, did I make antibody? I want to know how protected I am. So I'm going to say, no, don't get it yet. Not never, just not yet. And here's why. The tests are not standardized at all. If you get it at LabCorp, it's different than if you get it at my hospital, the hospital up I-95. Everyone's doing their own thing with the antibody tests, so they're not standardized. And here's the even more important part. We don't know what level of antibody is protective. Just because we can measure it doesn't necessarily mean it's enough to protect you. Now, we're going to have answers to those questions. We just don't have them at this exact moment. So later this year actually makes more sense. I wouldn't get the antibody test right now. I would wait until there's some standardization, and importantly, we know what antibody level is going to serve your needs. Is there antibody in my IVIG? Maybe I don't need to worry about the vaccine. Maybe I can get it from my immunoglobulin product. And the answer is, yeah, probably, but not for sure yet. So here's the data. So the antibody to SARS-CoV-2, the virus that causes COVID, is detectable in immunoglobulin products right now. It's there, right? There's enough people that have had the infection or been vaccinated so that there's detectable antibody in the products. But again, we don't know what level is enough to protect you. Those studies are being done right now. And again, if you're just a little bit patient, there will be answers by the end of the summer, I think. And now, I did talk about this at the national meeting. I'm just going to cover it quickly. What is COVID-19 like in people with PI? So one thing we've learned is that the risks are additive. If you're elderly, that is by far the biggest risk. And what's elderly? Over 70. So elderly is the biggest risk. Obesity is about a twofold risk compared to a healthy 30-year-old. Diabetes, again, about a twofold risk over a healthy 30-year-old. Lung disease, similarly. But all of those risks add up. So right now, it does not look like common variable or XLA is a risk factor for severe disease. But if you have common variable and obesity, common variable plus bad lungs, then you do have a risk attributable to the other organ system involvements. Are there any primary immune deficiencies where the risk is higher? Yes. As we get more data, it's becoming clear that there are a few. So there's an immune deficiency called APSED or APS1 due to mutations in a gene called AIR. Those patients do have a higher risk of severe disease. And then there's a tiny group of patients who have mutations in a set of genes related to interferon, and they have a risk of more severe disease. But those people don't have recurrent infections. They're not on immunoglobulin. The only reason their flaw in their immune system was found was because they have severe COVID. And then the last topic I'm going to talk about is long haul COVID-19. This is very much in the news, and I'm actually really glad there's a lot of research going on in long haul COVID-19 because a lot of it's directed at fatigue and brain fog. And these are two symptoms that a lot of patients with common variable have. And so it'd be nice to see if there are some commonalities, if we can learn something from the long haul COVID that might help people with CVID. So what constitutes long haul COVID-19? Usually it's defined as fatigue, brain fog, some continued smell and taste issues, but can also include these really diverse symptoms like anxiety, depression. Tics are now showing up as part of long haul COVID. So, if your eye twitches, and then prolonged breathing difficulties after COVID-19. Turns out it's actually really common. The percentage of people with these symptoms goes down over time. and it's more likely in the people that had more severe disease. Why am I talking about it? There are some risk factors that are coming up, but primary immunodeficiency is not one of the risk factors as far as we know. Are there treatments for long haul COVID? Right now, there's personalized rehabilitation. So if taste is your biggest issue, there's taste retraining. If there's anxiety, there are medications for anxiety. People are trying immune modulation, and I'm a little bit excited that that might have a benefit for patients with common variable who have fatigue. And then there's some efforts to kind of reset the brain chemistry. So I hope that answered your questions. We're going to have a couple of talks from sponsors, and then I'll come back and answer your questions.
Thank you, Dr. Sullivan. Wonderful information. Thank you, thank you. And now I would like to introduce my colleague, Colleen Brock, Program Manager of Education at IDF, and she is going to moderate the Q&A session. So Colleen, you and Dr. Sullivan can take it from here.
All righty. Thank you everybody for the amazing questions that were sent in before. I've been trying to follow all along with the ones that keep flying in. I will tell you right now, there's no way we would be here till midnight to answer every question. You have some amazing questions. So I'm going to try to go through them as quickly as possible. And if you still have a question afterwards that you don't understand, please contact Ask IDF and I will try to get that answer for you, or at least better explain an answer that you don't understand. So Dr. Sullivan, I'm going to go back to the study. We had a couple questions about the study that you had, the slide. Somebody questioned, what do you mean by CVID times 2? And what do you mean by CVID times 10?
I was just counting. So rather than write CVID 10 times, I was just trying to find a shorthand. So 10 times in the responders.
Okay. And I just wanted to clarify that. Also, there's a lot of, I think, misunderstanding what you mean by antibody disorders. So can you please name the antibody disorders that you are discussing? Because I'm getting questions about all of them and I'm not sure they understand they fall into that category.
Yeah, it is confusing, I have to say, even for immunologists, it's a crazy time. So, you know, there's a subset of patients with common variable that have known genetic defects, and so they might know their condition by their gene. So we just heard from Farming about APDS and PI3 kinase defects. So I have some patients who know the name of their condition because they know the name of their gene. And so they might say, hey, I've got PIK3CD. So some people think of their disease in that way. But all antibody defects are characterized by one or two things: low immunoglobulin, so low IgG, low IgA, and or low responses to vaccines. So you can have normal amounts of IgG, but you don't respond well to vaccines. And now I mean pneumococcal vaccines, and that's called specific antibody deficiency. So if your immunologist has ever said, gosh, you didn't make antibodies to this vaccine, or your IgG is low, you would be under the umbrella of an antibody defect. It's really a category to encompass all those folks who have some flaw in their ability to make antibody.
And can you list the most common of those, please?
Common variable immune deficiency by far is the most common. I would say X-linked A-gamma globulinemia is maybe the next most common.
And then how about specific antibody and IgA or hypogam?
So hypogam, also a close kissing cousin to common variable. IgA deficiency is an antibody deficiency, and I would expect that they would do well with the vaccine as well.
Okay, thank you. All right, so the hot topic in the news right now is the Delta variant. So we've had numerous questions on the Delta variant. Do we have any knowledge as to how patients with PI are doing with that variant in particular?
So there's no reason to think that the Delta variant would behave differently than the B.1.1.7 or the standard European virus, so the standard European virus was the first strain that we got in the US, with the exception of a tiny clump in Seattle. And then that was replaced by the UK variant, the B.1.1.7, that's now known as the Alpha variant, and now it's the Delta variant. There's no reason to think that the Delta variant is going to behave any differently in people with PI. It does have a couple of epidemiologic quirks. One is that it's more transmissible, and the second one is that younger people are more symptomatic with it. And by younger people, I mean not just young adults, even children are more symptomatic with the Delta variant than they were with Alpha or the original strain. But there's no reason to think that that necessarily means more severe or different disease in people with PI.
Do we have any idea at this point with studies how many patients in the PI community are getting COVID and doing well and recovering versus having severe disease?
We do. So I presented some of that work. At this point, there are now 6 studies. So there's a national study from Israel, a national study from Italy, one from the United Kingdom. And then there's an international collaborative study that I was a part of. And then there's a New York cohort that's been reported. They're all actually quite comparable. The rates of hospitalization and to pick hospitalization as the definition of severity, the rates of hospitalization don't seem to be much different overall in people with PI compared to the general population. Even within the PI population, age is still a risk factor for severe disease, and lung disease is a risk factor for severe COVID. But overall, there doesn't seem to be a risk directly attributable to PI that confers a risk for severe disease. It's really quite surprising, right? Most people with PI have been told their entire time since their diagnosis, oh, you're more susceptible to infection, you have to protect yourself. But COVID is a weird virus, it's a weird illness, and it's operating on a different plan. And so people with typical immune deficiencies don't seem to have an increased risk of severe disease. Again, age, obesity, lung disease, anything that's a risk factor in the general population would also be a risk factor if you have PI, but the PI per se doesn't seem to be a big risk factor.
We are hearing now about people who are vaccinated having breakthrough. Are people with PI more at risk for breakthrough because maybe they aren't producing enough antibodies, or do we have that knowledge yet?
Yeah, so there's a lot of modeling being done in the absence of knowledge and testing. So the thing that we're all waiting for is there's this amazing study of nurses in the United Kingdom where they're tracking what their antibody levels are and what their breakthrough infections are. So the higher your antibody, the more protected you are. So if you think back to that slide I showed, among the immune deficient patients, there were some who didn't make any antibody, there were some who made a smidge, and there were some who made normal amounts. The more antibody you make, the more protected you are, and the more antibody you have, the more protected you are from the Delta variant. So the Delta variant is defended by having antibody from the vaccine. But there's more breakthroughs with the Delta variant than there were with the Alpha variant. But the level of protection in the general population is almost as good for hospitalization. So most of the breakthroughs are mild symptoms, not hospitalization.
Okay. Recommendations for people with PI that get COVID. What should they do?
Yeah, same as the general population. So I know it sounds crazy to say this, but protect the people around you, right? What if you have an elderly aunt or a mother or a father? So protect the people around you. If you are walking and talking, there are 2 monoclonal antibody preparations that you can get. So in other words, if you're healthy enough to be at home, you don't need hospitalization. Many places for adults will offer these antibody preparations. So let's say, I don't know, you went bowling. I don't mean to impugn bowling, but you went somewhere where you're touching things and you're around other people. 5 days later, you have a stuffy nose and you feel a little punky, you get tested. So if you're at that stage, you can get these monoclonal antibody infusions that are like supercharging your immune system and giving you a head start against the virus. They're actually very effective at preventing severe disease. So they're not preventing the infection. You already have the infection. What they do is they prevent progression and severity. So if you live in a city, good chance is that the hospital near you will have it and offer it. It's only available in the first couple of days that you have symptoms, and only available for people on the outpatient side, not people that are hospitalized. So that's one thing you can do for yourself. If you don't have access to that, you live in a rural area, no one around you has it, don't panic. I think the likelihood of your disease progressing is relatively low. And the recommendations would be stay home, protect the people around you, and monitor your respiratory status.
Long haul, can you touch on, do we know anything about patients in the PI community? How many are getting long haul symptoms? How many are being affected? What do those symptoms look like?
I think that probably individual immunologists know from their own personal experience. It hasn't been published, and because I'm a pediatrician where long haul COVID is just not very common, I haven't seen it. So I don't have a great answer to that question. I would imagine that people with PI don't necessarily get more of it, but honestly, there's no data. And it's so common, right? Once people started measuring it and asking about it, it turns out it was half of the patients in a month. So it's really common in the general population. So it's going to be hard to know if people with PI have more of it. This is a terrible virus, right? It's terrible in the moment when people are sick with it. And then all of these long symptoms. This is a very weird virus that does peculiar things.
Amen. What is the likelihood of a COVID-19 vaccinated person who later becomes infected with the virus? So they've been vaccinated, they've had breakthrough, they're now infected. Can they spread the virus?
Yes. So if you have symptoms, you can spread it. In general, the people that have been vaccinated have far less viral counts than people that haven't been vaccinated. So the amount of virus in your body that you can spread tracks quite a bit with symptoms. The sicker you are, typically the more virus you have and can spread, but even asymptomatic people can spread it. The vaccine diminishes the likelihood of spread, but doesn't completely eliminate it.
Do monoclonal antibodies help with that at all? Is there any research?
I'm not sure. I don't know the answer to that.
Okay. Can you touch on people with B-cell deficiencies who are being treated for RA with rituximab and things like that? Are they at severe risk for disease? Are they at risk for the vaccine not working because they're on the treatments they're on?
Yeah, that's a great question and quite sophisticated. So if you've been given rituximab, you most likely don't have B cells. Now, if you're more than 2 years out from your last rituximab, there's some chance that your B cells have normalized. But if you're in the moment being treated with rituximab, you don't have B cells, and you most likely will not make an antibody response to the vaccine. But remember, you will get that T cell response, and that's not nothing. It's not as good as having antibody, but it's not nothing, and it will offer you a little bit of protection from severe disease.
Thank you. Okay, now we're going to move into vaccines. So a lot of questions about vaccines. A lot of the most common questions that I'm getting regarding boosters. So if somebody has done 2 mRNAs, should they do a J&J if they've had the antibody test and it didn't show anything? Or should they just do it because there was a study about transplant patients and they didn't respond well, so they gave them a 3rd one and seemed to boost it? Would that work for PI patients? Thoughts on boosters? When do we do it? What do we do? How do we do? Do we do it?
So remember that the commercial tests for antibody levels are still pretty pathetic right now. They will get better, I promise. So knowing what to make of that. So most of the antibody tests that are available clinically are plus minus tests, meaning they're just going to say you have antibody or you don't have antibody. There's not a lot of nuance. There are some labs that will give you a scale and tell you you've got 5 units or 10 units, but how that translates into protection is not clear yet. I'm not sure I could say that enough. So if you've had an antibody test and you have antibody, personally, I would hold tight until there's better testing and we know what level you're aiming for to get protective.
And how do I determine if the vaccine is safe for me to take? Are there parts in the vaccine that are going to come into me that are foreign? How do I know if I'm going to have a reaction, if I've had a reaction to other vaccines? What do I do?
Yeah, these are pretty reactogenic vaccines, the mRNA vaccines. Actually, even the Johnson & Johnson vaccine is pretty reactogenic. Reactogenic means causes fever, soreness, pain at the site of the injection. So those, I personally think those are expected side effects, right? These are strong vaccines. They're trying to kick up your immune system. So that's just your immune system working. So those are, to me, kind of expected side effects. I, to be honest, felt wretched after my second dose. I expected it. There's a lot of publicity around feeling crummy after the second dose. So the things that are side effects that are not unique to these viruses, but the ones that have gotten a lot of press are Bell's palsy, where your face is weak for a while. Usually it does recover, but your face can be weak. The Johnson & Johnson vaccine had a clotting issue. The myocarditis in the young boys that get it. But these are all rare. These are like 1 in a million. So remember, myocarditis was 1 in a million vaccines, but it's 2% of people with actual COVID. So shockingly, for such strong vaccines, they actually have quite a good safety profile that's quite comparable to the shingles vaccine, just to pick another vaccine. So it just depends on what you mean. If you think it's safe, you can expect some reaction. That's pretty typical. It's found in about 30% across all populations. But that, again, is expected because it's kind of punching your immune system up and saying, come on, boys, let's get to work. It's the other things that are super rare that I think people worry about, but they're super rare. And remember, a lot of these side effects are seen with other vaccines that most of us happily got.
We currently know, in the news, we've heard that the vaccine is lasting 8 months. Do we know whether that stands true for the PI community?
So if you think back to the slide that I showed with the antibody levels, you will remember that there were sort of 3 clumps of patients: the people who didn't make antibody at all. And for those people, we hope that the T cell protection will help them a little bit, and maybe they're on immunoglobulin and they'll get protection from the immunoglobulin that they're on. Then there was the clump in the middle that was roughly equal to the people that had natural infection. We know after natural infection that at 8 months, about half of the people were protected. So this is again from this study of United Kingdom nurses who've been so incredibly generous and have allowed themselves to be studied for all these months. So after natural infection, about half of the nurses were protected at 8 months. Remember, after the vaccine, you've got a lot more antibody. So we imagine, without knowing for sure, that that lasts longer. That's why there's a lot of effort in trying to figure out what antibody level is the magic level that confers protection, but we just don't know the answer yet.
Do you have any facts on people with DiGeorge syndrome getting the vaccine and how they're doing?
So I know for myself, just a handful of patients, they've actually responded quite nicely. So I do recommend it for all my patients with DiGeorge or 22q deletion. I think it's valuable. Many of those patients have heart issues, or they have obesity, or they have other issues that would in and of themselves be a risk factor. interestingly, having low T cells is not a risk factor for severe disease.
Why would untested mRNA vaccine be recommended when treatment with Ivermectin has been safely used for 30 plus years?
Yeah, ivermectin's a great drug. It just doesn't work for COVID-19. So in fact, there was quite a bit of testing. So there was a test done in the United States, but there have also been tests done in other countries, and they've all been quite consistent in showing that ivermectin is not helpful. So yes, it's a great drug, but it's a great drug for parasitic diseases, not for COVID-19. And while the mRNA vaccines, I get it. They're new, they seem scary, and RNA sounds like DNA, and it's easy to get tangled up in that. In fact, it's not a totally new platform. The mRNA vaccines were first developed for Ebola about 10 years ago. So it's not a completely new platform. People have been getting RNA vaccines for almost 10 years. So yeah, I get it. It's new and it sounds scary and it seemed kind of techy. But in fact, it's not a brand new technology, and there's quite a bit of experience with it. And think about this, at this point, millions of people have received those vaccines, millions. And most of the first people in the United States to get the vaccines were people in healthcare. And we were recruited to fill out a diary. I swear to you, this diary goes on and on and on and on. I'm still filling out my diary. So they're collecting information on long-term side effects. They're collecting information on fertility. Some people were worried about fertility. That data has already been published, and there's no impact on fertility. So these vaccines, I know they seem scary and the questions are great, but it's actually quite safe.
Thank you. Interactions between your IG replacement and the vaccine. Is there any coincidence with side effects? Is there a timing issue?
Yeah, I get asked that all the time. That's a great question. And actually, Colleen and I have talked about this a ton. So I don't see any reason right now to try and phase them, meaning try and pick a specific time, get the vaccine in your trough. At this point, I don't see any reason to do that. If the levels of antibody get very high in the immunoglobulin product, let me restate that. If the antibody to SARS-CoV-2 gets very high in the immunoglobulin products, there are reasons to maybe try and think about the timing of it, but right now the antibody levels in immunoglobulin products aren't that high. So right now I don't see any reason to try and figure out a timing sequence.
I'm not sure you'll know, but can an employer require a third-party review of medical records to see if I've had the vaccine? I don't want to risk my health on an experimental drug.
Yeah, that's a touchy question. So so I guess really the root of the question is, can the employer require employees to have the vaccine? And if they don't get it, can they then request medical records? So far, the companies that have been mandating the vaccine have so far allowed a medical exemption. So for the flu vaccine, just to pick the most common one that is mandated by employers, while they don't usually allow religious exemptions, most employers will allow medical exemptions. And I imagine the same will be true for most employers for the COVID vaccine. Just because there's a precedent, and so it would be hard to reverse that. And many employers aren't going to mandate it until the vaccines get full FDA approval, which is projected to happen in August. So some hospitals have done that, some employers have done it already, but I think after full FDA approval happens, I think then more employers are likely to mandate the vaccine.
My memory B cells and T cells are dangerously low. I have a diagnosis of specific antibody deficiency. Any new updates for people like me with my PID condition as it relates to the vaccine?
So in the study that I published, as well as the Israeli study, the Italian study, and I think the New York cohort, there were patients with specific antibody deficiency, and they all responded to the vaccine, as far as I can remember. I believe all patients with specific antibody deficiency have responded.
We know that NIH is doing a vaccine study with patients in the PI community. Do we know any early results, anything on it yet? Or is it still in the process?
It was presented at a virtual meeting I was at. It was more about what the process was. Their long-term goal is to understand whether there are variations in the human immune system, including people with PI, that predict vaccine responses. So they presented a little bit of data at this meeting, but it's going to be a year before they have the whole story that they want to look at.
Okay. CVID and lung disease with a partial lung removal, does that make the Pfizer vaccine less effective versus just having CVID as one medical question? Sorry.
There's no reason that having a partial lobectomy or a lobectomy would impact your vaccine responses. So it's really just your type of CVID. So remember, in the study I presented, slightly more than 80% of the CVID patients responded to the vaccine, but there were a couple of patients who did not respond. And right now we don't know what the difference is, although the authors of that study picked age as the variable that they thought impacted vaccine response in common variable.
Does steroid usage affect the vaccine, and would taking Dupixent affect when you should take the vaccine?
That's a really great question, and thank you for asking that. So yes, steroids do adversely impact the amount of antibody that you make after vaccination, and it's somewhat dose dependent. So if you're on 40 milligrams of prednisone, that's going to have more of an impact than if you're on 5 milligrams of prednisone. As far as we know, and there actually was an article just in last month's JACI, Dupixent does not impact either the disease or the vaccine. So again, these are early days in these studies, so I'm telling you what we know right now based on published data, but Dupixent does not seem to impact vaccine responses.
So if you're on higher doses of steroids, should you wait beyond the recommended time frame to get a second dose of the shot?
If you have a reasonable, so sometimes people get a pulse of steroids because they have a flare of something, and that pulse is a couple of weeks. If you have an expectation of coming off steroids within a couple of weeks, I would wait.
If one generally does not have antibodies and has T cells and B lymphocyte malfunction, will the vaccine work?
Yeah, I'm not going to be able to give specifics for specific people. I can really just reiterate the data that I shared with you. So in the common variable, typically about half of patients with common variable have T cells that are a little wonky and don't work so great. So we think that at least some of those people are going to respond to the vaccine, but we don't have the granularity to say, if your numbers are this, you will respond, and if they're this, you won't respond. We're just not there yet. So I can only just reiterate, the majority of people with CVID respond.
Do you have any anticipation when a vaccine will be available for the younger kids, 5 to 11?
Yes, so that should be this calendar year. Thank you for asking me an easy question, by the way.
Right. All right. We've touched on a lot of antibody testing questions, but there's still some more that are kind of floating around. Is there, I say, I'm trying to, there's so many. My antibody test came back IgG positive, IgM positive, IgA negative. Does this mean that my body didn't respond to, and all of my antibodies are from my IVIG?
No, it means you did respond. So pat yourself on the back. The fact that you have IgM positive, now with the caveat that the tests are not standardized, we don't always know what they're measuring. But in theory, if you have IgM, that's from your body, not the immunoglobulin product. So good on you.
So let's talk about antibodies in plasma. So we know they're starting to appear. At what point do you think they will become protective? Will they become protective?
So what I can tell you is there is this incredibly elegant model that actually measured different decay rates of the antibody, both after natural infection and from the Pfizer and Moderna studies. And then they measured the amount of antibody over the winter and tried to sort of project out based on vaccination rates. It's a model, it's not real life, but it's very carefully done. It's not just this hair, it's not someone sitting in the back seat with a pencil and paper. It's actually pretty carefully done and calculated. Their projection was that this summer, antibody levels in commercial immunoglobulin would be protective. But I want to say again, a model is not the same as real life. So what is it going to take? It's going to take a bunch of people who are on this webinar, particularly people with XLA that aren't making antibody responses to the vaccine. And it's going to take a big number of them to ask what's their level of protection. So if your only protection is coming from immunoglobulin, how protective is that? There's actually no substitute for looking at humans and asking what the infection rate is. It's unfortunate. We can model, we can look at mice, but in real life, we have to look at people. And so it's just going to take time to collect that data.
Do you see any products coming other than infusions that would be preventative for COVID for those who don't make antibodies?
Yeah, so these two monoclonal antibody preparations, one is by Eli Lilly, one is by Regeneron. Again, they're pretty available. You might have even seen their ads on TV. I get the sense that they're trying to encourage more people to use them. So here's the drill with these monoclonal antibodies. So these are like super powered antibodies, really high levels of antibody. They're made in a test tube and you get them by infusion. So what's the drill? You have to be within 2 days of the onset of symptoms. You have to be a high-risk person, which anybody with an immune deficiency would be considered high risk according to their definitions. And you have to have access to it. So most people can access these infusions at a large medical center. I haven't heard of like small clinics offering it, but your immunologist probably knows. And if you're near a large medical center, you ought to be able to find out if they offer it. So these monoclonal antibodies are produced, they've been tested, they are effective. It's just that they're fussy about how you have to get them. So if you're ever in the unfortunate circumstance where you're exposed to COVID, you develop symptoms, that's the setting where you would want to go and get one of these infusions, and they are actually quite effective. Do we have more than that? Not in the moment. So there are various antiviral drugs in development. You might have heard Tony Fauci talk about how necessary that is, but they're all in development. Whether they will make it to the point of getting FDA approval is impossible to say right now. So right now, what is out there are these monoclonal antibody preparations. And other than people in super rural areas, you ought to be able to find them and have access to them.
Let's talk about children. So COVID affects children with both IgA and IgM deficiency in what way?
So I'm trying to guess what's behind that question. So children are affected. So teenagers do get symptomatic COVID. Generally, the youngest kids, meaning less than 5, are not very symptomatic with it. However, they can transmit virus. And then there's this group between 5 and 10 that has minimal risk of severe COVID, but not zero. So there's sort of a gradient throughout childhood. Teenagers act much more like adults. The school group in the middle, sort of 5 to 10, they tend not to get very symptomatic, but they do get sick. More so, I shouldn't say specifically, more so with the Delta variant than with either of the two predecessors. I do not think there's any data suggesting that having a low IgA or a low IgM is in any way important for severity. Now, in a year, I might say something different, but right now, I just don't think there's any data to suggest that that's harmful or a significant risk factor for severe disease.
What level of vaccination among 12 to 18-year-olds in my hometown would be safe for my vaccinated XLA son to feel he has herd immunity protection?
Yeah, that's such a great question. I listened to this amazing podcast as I was walking home, and the woman that was doing the podcast said, you know, we should never have started talking about herd immunity because we don't know what level is important. So I'm just going to share with you the example that she gave, which I thought was so useful. She said for measles, you have to have 95% or higher of the population to prevent outbreaks. Measles is super contagious, probably more contagious than COVID. So we don't know what that magic number is for COVID. So there's a CDC guidance that the hospital that I work at has also chosen to use. If you are around friends and 75% of them are vaccinated and there's not much COVID in the general population where you live, it's probably safe to go out. I realize you want something a little more etched in stone than that, but I think it's valuable to recognize that the risk isn't an on-off switch, right? It's not like we're at a point where we can say there's no risk. Go back to doing whatever your life was like pre-pandemic. We're not there. But we also recognize that people have to lead their lives. And so the guidance, which I think is kind of useful, if non-specific, is to say, if you're in a room and 75% of the people are vaccinated and in your general community, the circulation is low, it's probably fine. If you live in, I'm trying to think where they're having a big outbreak. I guess LA just went into lockdown again. If you're in Los Angeles, maybe having 75% of your friends vaccinated isn't enough just because there's a lot of circulating Delta variant there right now. So this idea that there's kind of an on-off switch, I think we have to get away from it. I think there's a gradation of risk. And if you're super risk averse, maybe that's not enough for you. Maybe you need to have 100% of your friends vaccinated before you'll hang out with them. I have a friend who has said that. He said, I am not going to lunch unless 100% of the people are vaccinated. So he's more risk averse, and that's fine, right? We accept that people have had a different journey through this pandemic and have different risk assessments, and that's fine.
Can you touch on school a little bit? And every school is different, but what do you recommend for children who have a PI and are going into a school environment now where masks may not be required? Or you have children who don't have a PI but are coming home to a parent who has one and may be at high risk?
Yeah, Mama Mia. So among pediatricians, that's a key question. So I'm going to go back to the age effect. So a very young child, a 5-year-old, they probably weren't wearing their mask, or if they were wearing their mask, they were touching 100 things along the way anyway. So, but the good news is that they don't transmit very much. They just don't carry much virus in their body. And they don't get sick themselves, even if they have PI. So the risk to kids under 5 is really negligible, and they should go forth and do whatever activities they want. Again, this is my opinion. The 5 to 10-year age group is a little dicier. And I think while I have said to my patients, you should go to school, it is a little more nuanced than that. So what if the parent or the grandparent has major risks? Is that really so smart? I don't have a blanket answer for you. And then the teenagers have just the same risk, but honestly, the teenagers should be vaccinated. So I don't have a perfect one-size-fits-all answer for you. And I will just say, this has been the subject of at least 100 hours of discussion at my hospital. So the fact that I don't have a perfect answer, trust me when I say no one has a perfect answer.
No, very true. And now we're going to get into the really murky waters. As we know, different states in this country have different numbers of vaccinations and different numbers of cases. So how do people in the PI community move forward now? How do they feel safe? what can they do if they're going back to work, if they're, you know, what do they do? The people who are, they're scared.
Yep. So if you can work from home, and you're in an area that has low vaccine uptake and a big explosion of Delta variant, if you can continue to work from home and minimize your exposures, that's great. You do have some alternatives. So if the level of antibody in the immunoglobulin, if you're on immunoglobulin, this only applies to those people, the level of antibody is estimated to be protective now or shortly. So it's not like we're talking a year of this. We're talking probably a few months before we know how protective the immunoglobulin products are. So if you're on immunoglobulin, that will shortly confer some level of protection, even if imperfect. You do have access to these monoclonal antibodies if you should get sick to mitigate severity. So there are some fallback positions, but of course, prevention is always the best. Not everyone has the option of working from home, but I will take you back to a year from now, and masking is incredibly effective. So the first paper on the efficacy of masking is from the 1918 pandemic, where it was instituted at soldiers, where soldiers were living, and it was shown to be very effective. It's still true today. A mask will protect you. I know they're not the most comfortable thing on the planet, but a mask and good hand hygiene will help. And I work in a hospital environment where I worked on the COVID unit. And, you know, at first I had those big pepper hoods to try and prevent infection. And then after a while, they just said, no, you just need a mask. And so I was very nervous, but in fact, no one who worked on the COVID unit caught COVID wearing standard mask precautions.
So last question. A great majority of this community has been locked down since March. They've not left their home. They want to do what other people are doing, and they want to fly. They want to go visit family. They want to travel in a car. They want to go back to church. How safe is it for them to do that? And what do we do? They want to break their isolation, but not end up terribly, terribly sick.
Yep, I'm totally sympathetic. And I think we underestimated the importance of our social network for our mental health and well-being at the beginning of the pandemic, and really focused on lockdown and sort of neglected the fact that we are a social species. And part of me regrets that. I don't know that I could have made a different decision if I'd been in charge, which I was not. I think I might have made the same decisions until we had more information, but I totally hear you. And I will come back to the previous question and say masks are incredibly effective. So particularly for flying, my mom got quite sick and I had to make a series of flights. And this is now back almost a year ago. And I was super nervous, but actually we read about rage in the air and people not wearing their masks, but people were actually quite good about wearing masks for the most part. And I had a mask on. I washed out my chair like a mad woman. And so that's actually quite effective. That's not just my experience. It's also been documented to be effective. There's very, very limited evidence that there's any transmission on airplanes. So, and similarly in a car. So as long as you're masked, as long as you continue with the things that we don't love, but we know are effective, you should be fine.
And is there a type of mask that you recommend, especially when traveling?
So the N95s or the KN95s that kind of make a seal on your face, they're the least comfortable, but the most effective. The other alternative that's a little bit more effective is 2 cloth masks.
I want to thank you very much. I threw a lot at you. Like I said, the questions keep pouring in and we could be here till midnight. So, you know, I apologize that we didn't get to all of them. I hope that you have gotten some answers to questions, that you have found this to be helpful. Dr. Sullivan, I can't thank you enough. You are amazing. And
My
with that,
pleasure.
I'm going to pass it back on to Kathy.
Oh my goodness. The thank yous are flying in via the chat. And I cannot echo what Colleen just said enough, Dr. Sullivan. Thank you. Thank you not only for tonight, but thank you for being there from the very beginning and holding up that awesome model that you have of COVID and taking us through this time and bringing us through to the future. Thank you so much. And thank you to everybody who has joined us tonight. We still have about 200 people with us, and I cannot thank you enough for joining us tonight and for submitting your great questions. As Colleen said earlier, you know, if you have additional questions, you know, try to keep them as general as possible, but you are welcome to submit them through the IDF website. Ask IDF, it's right on the top of the page. Click on there and send your question in. In addition to thanking all of you and Dr. Sullivan and Colleen, you are amazing at asking all these medical questions. Thank you for keeping us going. Thank you for tying everything together. Amazing job, Colleen. Thank you to our sponsors tonight. And thank you from all of us at IDF for joining us tonight. And we look forward to rolling out some information about the IDF Forum series, Zebras Fit for Life. And everybody, take care, be safe, enjoy the rest of the evening and the upcoming weekend. Take care.